Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Naik, delighted to welcome you all to this fourth episode of Nephro Live. And today, we will explore a crucial and very important topic, uh, unmasking the dual threat, hypertension and CKD. And we are honored to have with us our esteemed co-director, Dr. Dinesh Kullar sir, who is the chairman and head department of nephrology and renal transplant medicine, Max Super Specialty Hospital, Saket, New Delhi. Dr. Kullar sir is going to moderate today's session. Dr. Kullar has played a very pivotal role in guiding insightful and impactful discussion in our previous session. So welcome, sir. And may I now invite you to introduce today's esteemed faculty member. Over to you, sir.
Thank you very much, and a warm welcome to everyone who have joined us today one more time. It's always a pleasure, and I personally am always looking forward to the next edition of this fantastic opportunity which Intas has given me to spread the message of chronic kidney disease amongst all my countrymen, those physicians who are in charge of dealing with people with any kind of kidney disease and especially chronic kidney disease. So this is the next edition today. We have already talked about a few of the definitions of chronic kidney disease, and then we talked about the symptomatology. And the last time we were talking about diabetes in relation to kidney disease. And today we move one step forward and we are going to discuss a very, very interesting topic, and that's hypertension in relation to chronic kidney disease, both as the cause or as an effect of the chronic kidney disease. And as always, I am going to be joined by one of the best names in the field of nephrology, at least I can think of in the across the country, and I'm sure those who have joined us today will not be disappointed again. And I am sure the kind of reviews we've had, they're very, very encouraging, and I can assure you this is going to be in the same league, if not better. We are going to request my very dear colleague from Max Super Specialty Hospital, Saket, Dr. Deepak Kumar Panigrahi, who is really a brilliant nephrologist who had completed his studies from the prestigious All India Institute of Medical Sciences here in New Delhi, and followed by a fellowship in renal transplantation. He is a member of various societies, both national, international, and he certainly has a keen interest in research activities. And I'm really honored and really privileged to have him in our department, because the kind of clinical equipment he has as far as the research trials are concerned is amazing. And so we definitely are able to analyze our data much more efficiently with him around. So after he gives us a brief talk about and set the ball rolling for today's discussion, we will have a panel of discussants, including none other than Dr. Gopala Krishnan. We had him as our opening batsman when we had started this program, the first edition, or the first of the series. This was about a year and a half ago. And certainly he needs no introduction. He's one of the best known nephrologists across the country, past director of Institute of Nephrology at the famous Madras Medical College. And then he's been a postgraduate teacher and teacher of teachers for almost so many years. And look at the number of people he has trained across the country. And he's also been an examiner at various universities, and including the PACES exam conducted by the MRCP. Many wonderful research publications to his credit, book authors which he has been, book chapters which he has authored, and certainly in recognition of his tremendous service to the field of nephrology, he's a recipient of the prestigious Service Excellence Award from the American Nephrologists of Indian Region, commonly called as ANIO. That was in 2021. He's been a principal investigator of many of the landmark trials, as you can see here, including Credence, Solidarity, Testing, Achieve, etc. And he's a reviewer, and doesn't come as a surprise for so many of the reputed journals across the globe. And certainly it goes without saying that he's held various prominent positions wherever people have actually required his services. Thank you very much, Dr. Gopalakrishnan, sir, for joining us one more time. And up next, we have another very dear friend of mine. It's a privilege to formally introduce Dr. Vinay Malhotra. But for those who belong to this part of the country, it's certainly he needs no introduction. He's a professor, Department of Nephrology, and he's also the medical superintendent at the prestigious SMS Medical College and attached hospitals in Jaipur, Rajasthan, and he's the ex-additional principal of the same medical college, as well as of the ex-medical superintendent. He's a subject expert of nephrology, helping the Ministry of Health, Government of India, come out with various policy matters and helping the government come out with the right way forward as far as the field of nephrology is concerned. He's a member of his hospital's ethics committee and a very popular speaker at the various forums across the country as well as internationally. And certainly he is, as I said, one of the very prominent nephrologists of the country. We now have Dr. Pratik Das, who is going to join us. I believe he's already done that now. Another very, very fantastic dear friend, very knowledgeable, who's tremendous experience, not just in the field of transplantation, but in all other aspects of nephrology. He's at the moment a senior consultant nephrologist and a teacher for the DNB nephrology program at, again, one of the very prominent hospitals in Kolkata by the name Rabindranath Tagore Hospital. He's been practicing for over 2 decades now and runs a very large volume of renal transplant. As I said, they do a lot of challenging and very difficult transplants, and with amazing results. His special area of interest is ABO incompatible, for which he has delivered talks at various centers across the world. And he has numerous publications to his credit, and was also and very deservingly awarded the famous prestigious Bansal Award for the young nephrologist way back in 2010, as well as he is a recipient of AFSN and FISN. He was, in fact, the organizing secretary of a very, very highly, I would say, successful conference, which was held in Calcutta in 2023. So next we have a person representing the Indian Army. As a matter of pride for us to warmly welcome Dr. Pavitra Dogra, Manu Dogra. He is a professor of medicine and senior advisor, Department of Nephrology, Army Hospital Research and Referral, New Delhi, and currently he's in deputation to Kargil area, where he's actually doing a fantastic job. So it's a matter of pride to have to know a person like Dr. Dogra, who is doing tremendous service to our countrymen, and as a nephrologist, and even at a very, very difficult and challenging place which is currently posted at, he's doing a human service to ensure that dialysis facilities and other aspects of nephrology care are made available to people in the far-flung area. And especially, again, we as a country would certainly want that our soldiers who are making sure that we have a comfortable sleep during the night, they are guarding our country, they are also taken care of as best as possible. And people like Manu Dogra are doing exactly that. He has a lot of interest in peritoneal dialysis, and he's gone out of his way to promote this very effective therapy. He was the formerly professor and head at the prestigious Army Hospital RNR, and was the past director of the Armed Forces Organ Retrieval and Transplant Authority. So it makes him a complete kind of nephrologist, not just all aspects of nephrology, but also making sure that he's doing a great social service to the country by way of the expectations we have from people like him. Thank you very much, Dr. Manu Dogra, for joining. And So we will at this stage request Dr. Deepak. Dr. Deepak, please go ahead with your presentation so that we can then have a fruitful discussion revolving around this very important topic. We all know that chronic kidney disease is it's like a chicken and egg kind of thing. We know that hypertension can cause CKD, and the vice versa is equally true. So what is the genesis? What is the pathogenesis? How do we take care of this dual threat is what Dr. Deepak is going to tell us today, followed by the discussion. Thank you very much, and over to you, Dr. Deepak. You may start, Dr. Deepak, now, please.
Yes. Um, Good evening, everyone. I'm thankful to Nephro Live and Dr. Dinesh Khullar for giving me this platform to speak about this beautiful topic, rather important topic of unmasking the dual threat, that is hypertension and CKD. So the topic is too large, and the time allotted to me is too less. That is only 15-20 minutes. So I'll touch each and every aspect of hypertension and CKD briefly, so that it will be fruitful to your clinical practice on day-to-day basis. So, as we all know, hypertension is a major public health issue and one of the most common lifestyle diseases. In India, the number was around 118 million back in 2000, and now it is expected to be more than 250 million in 2025. And in chronic kidney disease, we will encounter in our cohort of chronic kidney disease patients, around 80 to 85% of the individuals are found to have hypertension. And this number increases to around 90 to 95% in stage 4 and stage 5 chronic kidney disease. So it is one of the most common modifiable risk factor for CKD progression. And we can encounter all variants of hypertension like treatment-resistant hypertension, elevated nighttime blood pressure, MAST hypertension, white coat hypertension, every kind of hypertension you'll find in our cohort of patients, the CKD patients. So in CKD, if there's uncontrolled hypertension, it will lead on to more proteinuria, more EGFR decline, more progression, and finally all kind of adverse outcomes, including cardiovascular and cerebrovascular morbidity and mortality. So as you will know, uncontrolled hypertension can affect each and every part of the body. In the brain, it can cause stroke, it can cause cognitive impairment, vascular dementia, it can cause peripheral vascular disorders, it can cause glomerular sclerosis, albuminuria, CKD, kidney disease progression. In the heart, it can cause acute coronary events, left ventricular hypertrophy, LA and LV dilatation, atrial fibrillation, and hypertensive nephropathy. So this implies that the control of hypertension is extremely essential to prevent all this kind of hypertension mediated organ damage. So this is one of the Korean study where you can see if there is an increasing SBP trajectory compared with the stable BP trajectory, increasing SBP trajectory was associated with a higher hazard risk of CKD progression, while decreasing of SBP trajectory showed a similar risk to non-hypertensive individuals with chronic kidney disease. This is from another study, the From J study, where they have shown that uncontrolled blood pressure of more than 130 by 80 millimeter of mercury increases the hazards of kidney disease progression as compared to a blood pressure control of less than 130 by 80 millimeter of mercury. In this slide also, we can see that the cardiovascular risk increases with uncontrolled blood pressure. Similarly, the stroke risk is also increased with uncontrolled hypertension. So, as far as the definition of hypertension is concerned, a blood pressure of more than systolic blood pressure of more than 140 millimeter of mercury and or a diastolic blood pressure of more than 90 millimeter of mercury constitute a definition of hypertension. So, this definition is for the latest guidelines of European Society of Cardiology 2024 guidelines, and it is pretty much similar to the previous guidelines also. So, how do we measure our blood pressure? It should be measured in a standardized way. Your patient should be seated comfortably on a chair with his back supported, with his feet flat on the floor, and he should not be talking around during the measurements or few minutes before the measurements also. And the cuffs should be well tied, and the mid-arm should be at the heart level, and the arms should be bare and resting on the table. And we all know about all the standardized BP measurement process. How it should be done in a quiet room in a comfortable temperature. Your patient should not be drinking coffee, alcohol, nicotine, exercise at least 30 minutes prior to the blood pressure management. He or she has to empty his bladder before blood pressure measurement, and you have to take more than equal to two measurements and there should be a gap of at least 30 seconds, preferably 1 to 2 minutes between these measurements, and you have to take the average of the measurements and finally record your blood pressure chart. So we can also diagnose hypertension through ambulatory blood pressure monitoring or home BP monitoring. These are extremely essential in diagnosis of hypertension, detection of white coat hypertension, detection of masked hypertension. However, in detection of circadian BP patterns and detection of nocturnal BP pattern and confirmation of true resistant hypertension, ABPM is extremely essential. However, ABPM, the process is cumbersome. You have to get attached to a machine for 24 hours. You have to pay the cost. So these things are for one-time diagnosis only. But for regular assessment, regular monitoring, long-term follow-up, home blood pressure monitoring is too good. And we all should counsel our patients to get a automated machines at their home and measure it. At least 2 measurements within 1 minute with 1 minute interval in the morning and in the evening, at least 5 days, and preferably 7 days in the initial diagnosis, then 1 or 2 per week, then once per month is for long-term follow-up. A blood pressure of more than 135 by 85 millimeter mercury in home blood pressure monitoring constitutes the definition of hypertension. And this is the most cost-effective way of monitoring your patient who are chronically hypertensive and are on different drugs. And home blood pressure monitoring is found to be correlated more closely with LVH and adverse cardiac outcomes. So home blood pressure monitoring is the need of the hour, and all of our patients should be counseled to get their home blood pressure monitoring at home. So whether hypertension comes first or the CKD or the kidney disease is the harbinger of hypertension, that is a matter of debate. We do not know what has come first. But suppose our patient is hypertensive, then hypertension definitely adversely affect our kidneys. It will affect the efferent atherosclerosis begins, and finally there is luminant stenosis. The counter-regulatory or the autoregulatory mechanisms of the kidneys are affected, leading on to glomerular injury and proteinuria. And more proteinuria, more renal ischemia that can lead on to reduced medullary blood flow, glomerular sclerosis, tubular interstitial injury, and all these things contribute to progressive renal damage. And if the renal damage is happening, and our kidney is an important organ, which is the master controller of the blood pressure. So with renal parenchymal damage, there is definitely more sodium and water retention. There is activation of the RAS pathway, decrease in the vasodilatory pathways. All these things lead on to increased cardiac output, increased peripheral vascular resistance, and hypertension, uncontrolled blood pressure, and the cycle continues. So whether hypertension comes first or the kidney disease comes first, that we do not know. But as a patient, I would like to be diagnosed as hypertensive first, because with controlled hypertension, I probably would not develop chronic kidney disease. So regarding management, we have to do a thorough history and physical examination. We have to ask the onset of hypertension, the age of onset, the patterns of blood pressure derangement, and in physical examination, at least we have to measure blood pressure in all the 4 limbs, both the upper limbs and both the lower limbs at the first visit at least. Otherwise, we will be missing coarctation of aorta and Takayasu aortoarteritis. So if thorough history and physical examination is extremely essential. We have to rule out secondary causes of hypertension, the endocrinological causes, the neurological causes, the drugs which can cause hypertension. We have to rule out all the secondary causes of hypertension before labeling it as an essential or primary hypertension. We have to do the necessary blood, urine, and other investigations to see whether there is any hypertension mediated organ damage or not. We have to risk stratify our patient. Risk stratification here means we have to estimate the cardiovascular risk in cases of uncontrolled hypertension, so that we can effectively manage our patient and we can give importance to necessary part of their management. Diet and lifestyle modification is extremely essential, because without this preliminary step, this is the first step in managing hypertension. You have to see the dietary compliance, see the dietary restriction, if the patient is following or not, see the lifestyle of the patient, whether it is sedentary or active lifestyle. These things definitely contribute to hypertension management in a greater way. And finally, the pharmacotherapy, and that is the most important part of hypertension management. So at the first visit, you have to rule out the secondary hypertension. And whenever you are encountering a young hypertensive or a child who is hypertensive, if there is a worsening of hypertension in a patient with chronically stable hypertension, if you're encountering a case of resistant hypertension or an hypertensive emergency or extensive hypertension mediated organ damage, or any clinical or biochemical features suggestive of endocrine causes, like your patient is having hypertension, hypokalemia, alkalosis, then you have to think of some endocrine cause and rule out the causes accordingly. So obstructive sleep apnea is an definitely an important entity that needs to be taken care of. Otherwise, your blood pressure control will be suboptimal. So we have to see the symptoms and signs of other endocrinological causes like pheochromocytoma, any history, and manage it accordingly. So all these causes of secondary hypertension, you all know, we have to rule them out with our clinical history, physical examination, and clinical and biochemical testings. So how do we predict the cardiovascular risk in hypertensive patient? So we have to see whether the patient has got any established clinical cardiovascular disease, like whether he has previously had any heart failure or a coronary event, whether he is having any kidney disease like eGFR less than 60 ml per minute per 1.73 meter square, or he is having albuminuria of more than 30 milligram per gram of creatinine, or other forms of hypertension related organ damage like cardiovascular remodeling or vascular or peripheral vascular disease, whether he is diabetic or not, whether he has got familiar hypercholesterolemia or not. All these things can contribute to adverse cardiac outcome or cardiovascular outcome in the pre-hypertensive range also. So you have to assess all these things clearly so that we can risk stratify our patient and start the therapy accordingly. So dietary and lifestyle modification is the first and preliminary. This is the step one of hypertension management. We have to decrease their salt intake, preferably to less than around 2 gram per day. We have to increase their potassium intake. We have to increase their physical activities, aerobic exercise training of at least 150 minutes per week of moderate intensity is definitely beneficial in blood pressure reduction and reduction of the cardiovascular risks. You have to stop or reduce the alcohol intakes. We have to tell them to stop smoking. All these things can definitely lead on to a better weight control, better blood pressure control, and reduction of the CV risk eventually. So with salt restriction, whether you are on a DASH diet or a controlled diet, if you are restricting salt, definitely you are going to lower your both systolic and diastolic blood pressure. So when to start therapy or pharmacotherapy for hypertension chronic kidney disease? So the KDIGO guideline was published in 2021. They did not directly specify any threshold for initiating antihypertensive medication. However, the European Society of Hypertension, those guidelines are endorsed by the European Society of Nephrology, European Renal Association, and the European Society of Cardiology. The ESH guidelines were published in 2023 and the ESC guidelines were published in 2024. They have both advised to start therapy if systolic blood pressure is more than equal to 150 millimeter of mercury and or diastolic blood pressure of more than equal to 90 millimeter of mercury. However, you have to risk stratify your patient. If his or her blood pressure is 130 to 139 systolic and diastolic blood pressure is 80 to 89 millimeter mercury, and you have to treat them accordingly. Both the guidelines they endorse the similar values. And what should be the target blood pressure in chronic kidney disease? The KDIGO 2021 guideline says the adults with high blood pressure and CKD be treated with a target systolic blood pressure of less than 120 millimeter of mercury, and when tolerated, using the standardized office BP measurement technique. However, the ESH and the ESC guidelines, they are of little different opinion, and their primary goal is to lower the office blood pressure to less than 140 by 90, and if tolerated to less than 130 by 80. So from where did all the evidences for the KDIGO 2021 guidelines come, so that intensive blood pressure control was defined as the need of the hour? So the initial study, the MDRD study, which was the first study, these studies were performed in a CKD population, chronic kidney disease population. The MDRD study, the ASK study, and their primary outcome was renal outcomes only. So in the initial MDRD trial, which was the follow-up of 2.2 years, they could not find any difference between the intensive control and the standard control blood pressure group. However, a subsequent follow-up study of 10.7 years, they could see that low target blood pressure was associated with a reduced risk of ESKD and the composite ESKD or death. Similarly, in the initial ASK trial of a follow-up of 3.8 years, they could not find any difference. However, in the subsequent ASK trial follow-up of around 12.2 years, they initially could not find any difference between the composite outcome of doubling of serum creatinine and ESKD or death. However, they could see a benefit in the cohort of patients who had a proteinuria of more than 220 milligram per day. So, next they have combined the data from the MDRD and the ASK trial and the cohort phases combined, and the median follow-up around 14.9 years, and they could find low target blood pressure was independently associated with a low risk of end-stage kidney disease and death. And all these things are compounded by the sprint trial, which was published in 2015. And there, in the sub-analysis of the CKD patient, CKD cohort group, they could find the low target blood pressure was associated with the overall lower all-cause mortality. So from all these data, actually, KDIGO guidelines, they've incorporated that intensive blood pressure control is the need of the hour. And with intensive blood pressure control, we can reduce proteinuria more, and we can prevent CKD progression in a robust way. However, the ESC and the ESS guidelines, they are of the opinion that the sprint trial has not included the diabetic patients, and they have not and usually in the office blood pressure measurement, we do not follow the standardized protocol. So if we are targeting a intensive control of less than 120 millimeter of mercury with normal kind of measurement that we usually do in the offices, then we might encounter more of hypotensive episodes rather than benefit of the patient. So what are the choice of therapy that we have, and what are the drugs that we have in our armamentarium? And first and foremost is the RAS inhibitors, like angiotensin converting enzyme inhibitors and the angiotensin receptor blockers. Then we've got calcium channel blockers, diuretics, both thiazide and thiazide-like diuretics, and beta blockers. Additional classes of drugs includes like steroidal mineral receptor antagonist, loop diuretics, alpha-1 blockers, centrally acting agent like clonidine, vasodilators, and special comorbidities that angiotensin receptor nephrolepsin inhibitor groups, ARNI groups, and SGLT2 inhibitor and non-steroidal mineral receptor antagonists. So, for treating hypertension and chronic kidney disease, KDIGO recommends that we should be starting a RAS inhibitor, either a ACE inhibitor or an ARB, for people with high BP, chronic kidney disease, and moderate to severely increased. And we need to start with or without dialysis. We do not have to see. We have to start just blindly ACE inhibitor, ARBs, taking care of all the side effects that can happen. But we have the starting drugs should be RAS inhibitor only. So for the European Society of Hypertension for CKD, they have also endorsed the same principle. And from CKD 1 to 3, if the eGFR is more than equal to 30 ml per minute, they have advised to start with AC inhibitor ARBs plus double drug combination of calcium channel blockers or a thiazide or thiazide-like diuretics. In the step 1, if it is not controlled, you have to add all the three: the AC inhibitor ARBs, CCBs, and diuretics. And if there is true resistant hypertension, you can add on some mineral receptor antagonist or a beta blocker or a alpha-1 blocker or a centrally acting agent. But if your patient is in CKD stage 4 or 5, you have to add a loop diuretic instead of a thiazide or thiazide-like diuretic, because their action at this GFR is a little questionable. That we'll discuss again. So if there is any true resistant hypertension, you can add a thiazide-like diuretic like chlorthalidone in the CKD stage 4 and 5 group, beta blocker, alpha-1 blocker, or a centrally acting agent. And you can add SGLT2 inhibitor and findinon as per the current guidelines. So when do we stop RAS inhibitor? This recently published Stop S investigator trial. They have studied around 411 adults of stage 4 and stage 5 CKD, and in around 50% of cases they continued RAS inhibitor, and in 50% of cases they discontinued RAS inhibitor, and they did not find, after 3 years of follow-up, they did not find any difference in the primary outcome of eGFR decline, or in the secondary outcome of ESKD or RRT initiation, or any difference in major active cardiovascular event. So among patients with advanced and progressive chronic kidney disease, the discontinuation of RAS inhibitor was not associated with any in between group differences in long-term rate of eGFR decline. So as per this study, there's no need to stop your RAS inhibitor, because they have got extremely beneficial effect on your kidneys and your heart. Next are calcium channel blockers that we all know about, the non-dihydropyridines like verapamil, diltiazem, and the dihydropyridines like nifedipine, benidipine, amlodipine, cilnidipine. So actually, all the calcium channel blockers are not similar. They act upon different type of calcium channels. Like amlodipine acts on the L type of calcium channels. Cilnidipine acts on L and N type of calcium channels, and ephedrine or azilipine acts on L and T type of calcium channels. The L type of calcium channels are they are found in the efferent arterioles. So amlodipine blocks the L type of calcium channels, so it dilates the efferent arteriole and it can worsen your proteinuria. But cilnidipine and azilipine and ephedrine, they act on L and N, L and T, type of calcium channels, and they are found to have decreasing effect on glomerular pressure and thereby reducing proteinuria. So diuretics are an important class of drugs, and the three diuretics, those sodium potassium chloride cotransporter, the loop diuretics, and the thiazide or thiazide lag diuretics that blocks the sodium chloride transporter in the descending collecting tubule, and the mineralocorticoid receptor antagonist that acts on the distal tubule. All the three are very important in hypertension management in chronic kidney disease patients. So the thiazide diuretics, they cause natriuresis and decrease extracellular volume. It's an acute effect, they decrease cardiac output. However, this decrease in cardiac output can activate the RAS and the sympathetic nervous system, and there will be a compensatory salt and water reabsorption. But with chronic use, there is decrease in peripheral resistance because of activation of the vascular potassium channels, inhibition of the calcium channels, releasing of the relaxing factors like nitric oxide and prostaglandin. Thereby, their net antihypertensive effect can ensue after some time. So chlorthalidone, thiazide-like diuretics that that is being studied in advanced CKD, and they have studied studied in a cohort of stage 4 CKD patients, and they have found that with advanced chronic kidney disease also and poorly controlled hypertension, addition of chlorthalidone to other antihypertensive medications improved blood pressure control at 12 weeks as compared with the placebo. However, the risk of hypokalemia, hypomagnesemia, hyponatremia, and increase in serum creatinine was more in the chlorthalidone group. But it can add on to your blood pressure control in an effective manner in stage 4 CKD also if you are giving chlorthalidone. So beta blockers use is not like first line in case of hypertension management in CKD, but if your patient has any kind of cardiac issues like chronic or acute coronary syndromes, post-myocardial infarction state, heart failure with reduced ejection fraction or preserved ejection fraction, of your patient is a pregnant patient, any hypertension disorder in pregnancy, you can definitely or safely use beta blockers in blood pressure control also. So next is about finerenone, the non-steroidal mineralocorticoid receptor antagonists. This is one of the newer drugs that has been used for diabetes with chronic kidney disease for proteinuria. But in the Fidelio CKD DKD investigation, they could found that the cardiorenal outcomes improved with finerenone, irrespective of the baseline office systolic blood pressure, and there is reduction in office systolic blood pressure that accounted for a small proportion of treatment effect in cardiorenal outcomes. So finerenone reduced office SBP across baseline SBP quartiles, including patients with baseline office SBP of around more than 148 millimeter of mercury. Similarly, the SGLT2 inhibitors, the gliflozins, these are the molecules you can keep them in every aspect of your body. They are cardioprotectant, they are nephroprotectant, and now you can use them for blood pressure control also. So in this credence trials also in people with type 2 diabetes mellitus and chronic kidney disease, canagliflozin lowers systolic blood pressure across all BP defined subgroups and reduces the need for additional BP lowering agents. Similarly, in the DAPA-CKD study design, in patients with CKD and albuminuria, treatment with dapagliflozin resulted in a modest reduction in systolic blood pressure. And finally, about the angiotensin receptor neprilysin inhibitors group, the valsartan and sacubitril group, they are also very helpful in heart failure cases, and they are also now known to have an antihypertensive effect. And we can use them as an antihypertensive drugs as per the situation if there is heart failure or if there is heart failure. So finally, resistant hypertension. It is defined as the uncontrolled blood pressure of more than 140 by 90 millimeter mercury, despite you are using like more than equal to 3 antihypertensive drugs, including 1 diuretic. So you have to rule out and confirm the true resistant hypertension by ABPM or home blood pressure monitoring. You have to verify the medication adherence. You have to exclude the secondary hypertension. Once true resistant hypertension, which almost accounts for around 5% of cases, is diagnosed, then you can just add a mineralocorticoid receptor antagonist if your eGFR is more than equal to 30 ml per minute, or a beta blocker or an alpha blocker, or a centrally acting agent, or consider renal denervation if your GFR is more than 40. If your GFR is less than 30, then you have the choice of adding chlorthalidone that we just have seen in the CLIC trial, and you can add beta blocker, you can add alpha blocker, and centrally acting agent. So regarding our dialysis population, hypertension is a common phenomenon that is encountered around 15 to 30% of cases that is known as intradialytic hypertension. We do not have any specific definition when to define an intradialytic hypertension. However, the KDO controversy a conference held in 2020, they have suggested definition like if an systolic blood pressure rise of around 10 millimeter of mercury from pre to post dialysis in hypertensive range in at least 4 of the 6 consecutive dialysis treatments, then we should evaluate for intradialytic hypertension. Various factors like volume overload, electrolyte imbalances, increased sympathetic nervous system activation, increased endothelin 1 activity, increased RAS activation, atrial stiffness, all these things can contribute to higher blood pressure or hypertension during dialysis. And we have to take a note of all these drugs which are dialyzable during dialysis. You have to treat intradialytic hypertension accordingly with a non-dialyzable drug. What are the interventions that we have got in management of hypertension? One is renal artery devascularization that we utilize in few select cases of worsening kidney function due to ischemic renal disease or uncontrolled hypertension despite multiple drugs, failed medical therapy, and you have got one renal artery stenosis or atherosclerotic renovascular disease in one of the kidneys, then you can try renal artery revascularization. Or there may be recurrent hospitalization for acute flash pulmonary edema without any obvious cause, then your patient might need renal artery revascularization. And regarding renal denervation, RDN can be considered as a treatment option in patients with eGFR more than 40 who have uncontrolled blood pressure despite the use of various antihypertensive drug combination therapy. And RDN can be considered as an additional treatment option if there is true resistant hypertension and if your eGFR is more than 40. What is in future? What drugs we have with us for as an antihypertensive agent in future? So if we see the RAS pathway, so we have got neprilysin inhibitors with us right now, and if we stop the supply of angiotensin through the siRNA like zilebesiran, this is the new drug that inhibits the production of angiotensinogen. So we can just cut short the downstream pathway. So there is a phase 1 trial that was completed with zilebesiran, and the results are positive. This is an injectable drug, and few injection related side effects were there, but there is no gross side effects that is encountered in the phase 1 study. Next, we have got AC inhibitor, ARBs that we all know, DRE that has failed in the practice. We have aldosterone synthase inhibitor, the baxdrostat, that is in phase 2 trial was published. So, this is also in the pipeline, but both for the management of hypertension and reduce the progression of CKD. So, baxdrostat is the next molecule probably that we are waiting for the effects to see. Next are steroidal MRA we have discussed, non-steroidal MRA we have discussed, and finally the endothelin receptor, the actual site of action. We have got a dual endothelin receptor antagonist, that is aprocitentan, and it has completed its phase 3 trial, and it is probably has been approved in US, but somehow it has got teratogenic effect and and then propensity to have fluid retention. So these things are need to be taken care of, and we might see this drug in near future in our centers too. So finally, hypertension management is not like just to measure a BP and start a drug. So we should treat our patient holistically from head to toe. So first one and foremost thing is lifestyle modification, diet. You have to talk to your patient. You have to involve a multidisciplinary medical team, a cardiologist, an nephrologist, and an internist. All can help. A counselor, a nursing practitioner, all can help in a dietitian. Especially the role of dietitian is definitely very, very, very important. You have to talk to the family. You have to support the patient, and you have to tell them how to take blood pressure at home. You have to tell them the importance of home blood pressure monitoring, how to take self care, and how to be confident. Do the necessary amount of aerobic exercises, yoga, and everything. All small things can make a huge difference if we get all these things done along with your regular medications. Compliance to medication is very, very important. So all these things are being done to prevent the end organ damage or the hypertension mediated organ damage that can endanger the life of the patient afterwards. So the sooner the better. So prevention is better than cure. So once hypertension is diagnosed, we should work in all these aspects to control hypertension and prevent further progression of the disease. Thank you very much.
Thank you very much, Dr. Deepak, for a very wonderful presentation. And you very nicely and appropriately summed up what we all, as physicians, need to remember while managing our patients of chronic kidney disease. Because, as you have rightly pointed out, it's an integral part of our care towards of these patients, because hypertension is rampant. So that again brings us to the point from where we started, chicken and egg kind of situation. So my opening question is going to be to Dr. Gopalakrishnan, with all his tremendous experience. Dr. Gopalakrishnan, you have to clarify one more time for us, which is the egg here and which is the chicken, whether hypertension was the cause or the effect. And so many times it becomes very difficult. So I would start by saying that every time a patient comes to us, then says, okay, I've been diagnosed as chronic kidney disease. And our question is, what caused it? So they say they have been to various doctors and they've said it is the cause is hypertension. And if the next question is, how long have you been hypertensive for? They say, I got detected just about 6 months ago. So obviously, we know hypertension of just mere 4 or 5, 6 months or years duration may not qualify to be labeled as the cause. In all probability, that was the effect. But I would request the most experienced person here today, and a person who is always looked up to as a great teacher, Dr. Gopalakrishnan. Please clarify for the people who have joined us today the differentiation.
Very good evening. First of all, my best wishes and warm regards to the co-panelists and to you, Dr. Dinesh Kudar, as well. Thanks, interest. This question, which came first is always a big mystery. Most of the times you'll not be able to unravel it. But more than 50% of the instances, we are pretty sure about the etiology of the kidney disease. For instance, a known glomerular disease, glomerulonephritis, going in for CKD. Obviously, the hypertension is not primary over there. And a known reflux nephropathy and ADPKD, and so on. Like known etiological factors for CKD, the problem does not arise at all. The question arises, as you have said, the first time diagnosis of CKD and hypertension together, that's very difficult to say. And the term hypertensive nephrosclerosis, actually, it is not very much encouraged nowadays. Hypertension at the maximum can be a great contributor and promoter for CKD progression rather than the initiator. Of course, it causes injury. Again, the vulnerability to go in for CKD due to hypertension per se, again, there is a lot of ethnic differences. It varies between Caucasians and blacks and the Asians and so on. And again, the APOL1 gene polymorphisms, those who have that, the hypertension contributes significantly for CKD progression and so on. And now the current knowledge is that the great Brenner's theory, the people born with low birth weight, the unfortunate persons with low birth weight, in all likelihood, they are born with less number of nephrons. So these people are simultaneously vulnerable for hypertension and CKD together. The primary driver there is the absolute number of nephrons. A practical point I would like to highlight here is that not infrequently I do come across, even last week I came across one young person, a preventable tragedy kind of. Thing is that hypertension detected when he sustained CVA, like stroke, ischemic stroke. And it was seen by many subspecialists and internists and so on. With lots and lots of difficulty, there was not even semblance of control of hypertension. At the lowest BP documented was 150, 100. It goes up to 200, 220 and so on. Stroke on one hand. And kidneys are almost borderline. You can't do biopsy, subnephrotic proteinuria. One clue that it is something very peculiar is that in spite of rising creatinine, potassium was low. So that is a clue. It is kind of activation of the renin-angiotensin system, and a young person to have that, there is no renal artery stenosis that has been proved. There has been ultrasound, Doppler is normal. So obviously, it is a monogenic hypertension like Little's and so on. Now there are facilities for confirming that. Even if you don't have the facilities for confirming that, in such a situation, you employ spironolactone. Spironolactone takes at least 5 to 7 days to start acting. In such a situation, even after spironolactone addition, the BP does not come down. It is Liddle syndrome unless proved otherwise. Next thing you have to do is that you have to search for amiloride. It is available as Nephro and so on. After putting amiloride, the BP just melted down. But unfortunately, the damage has already been done. And of course, in spite of that, after control of blood pressure, the creatinine came down significantly. So the importance of holistic assessment, that's very important, as Pani Grahi nicely mentioned. It is not just measuring the BP. At least once, when a new hypertension is diagnosed, head-to-foot examination for all the peripheral pulses and checking BP in all 4 limbs and looking for presence of abdominal bruit and at least doing 1 serum electrolytes, all this really helps. Thank you.
Well, thank you very much. That's very, very informative. And I think Dr. Balakrishnan has made a very pertinent point that when you find it difficult to control blood pressure, it would be wise on anyone's part to refer to a person who has more experience, because we know there are enough number of drugs available in our kitty, and we do tend to use them. But then I think the moment you come across a person where it is not getting under control, it should alert you to the possibility that maybe you're dealing with something not ordinary. So certainly, point well taken. And I think, if I may add, hyperaldosteronism, the Conn syndrome, is a very underdiagnosed condition. And when you refer to something like hypokalemia, I would certainly also want to rule that possibility out as well, and the results can be very gratifying. Dr. Vinay, this one is for you. Dr. Gopalakrishnan has said that, okay, well, it becomes very difficult at times to figure out which came in first. But supposing it's hypertension first, and if you were to believe that uncontrolled blood pressure can certainly destroy someone's target organs, including the kidneys, do you think it is preventable? Do you think if we really press very hard to the patients that you must control your blood pressure, and it is not just taking the medicines, it is, as Dr. Deepak has told us, be very particular about the targets which we have in mind. Dr. Vinay, please.
Yeah. So good evening to all. Yeah, so the term benign nephrosclerosis is not that so benign. We all know, and for hypertension to cause chronic kidney disease, it should be long-standing, uncontrolled hypertension. As Dr. Deepak also mentioned in his concluding remarks, that it should be the sooner the better, and prevention is better than control. So we know that this long-standing hypertension will lead to arteriosclerosis, it will disturb the autoregulation of the kidney, and at least if it is not leading to CKD, it will be a contributor or promoter of CKD. So to prevent the kidney damage and development of CKD with primary systemic arterial hypertension, the optimum blood pressure control is very important. So sooner the better. Now we have the guidelines, we have the target. So it is always better to treat to the target. And now we know that the lower the better. Even the KDIGO 2021 is saying that systolic should be less than 120 or reduce as much as it is tolerated. So to prevent the complications, the cardiovascular morbidity, mortality, definitely we have to control the blood pressure as soon as possible.
So this one again is for Dr. Gopalakrishnan. Dr. Gopalakrishnan, sir, I mean, Dr. Vinay and Dr. Deepak have given us very stringent targets. Do you, with all your experience, believe they are achievable? It's very easy to say, okay, a patient of chronic kidney disease has come to you, his blood pressure is 170 by 100, it's 180 by 90 or whatever, and gives you restless movements. And you set about controlling the blood pressure. And you have that kind of stringent target in your mind. How often are you able to actually achieve that kind of target in your patients?
It's very unfortunate. Not even 50% of the times we are able to achieve. And again, it is very tricky in the sense that by checking blood pressure in the office, you cannot jump into any conclusions. The prevalence of white coat effect is pretty high. So what I do is that I by using innovative ways of advising and enthusing them, I have in most of our patients, more than 75% of my patients, I can proudly say that I have succeeded in convincing them to get one a BP apparatus at home. And what I do is that I request them to keep checking BP randomly in different times. And whenever they check BP, to have a handwritten record. So during every visit in the office, I have a profile of BP readings. So instead of just relying on one BP reading, I do that. That really helps. And when there are wide variations between the office BP recording and the home recording, in such patients, I request them to undergo ABPM, 24-hour ambulatory blood pressure monitoring. That really helps. That gives a lot of information. This is one point. Coming to the next point is that the target of preferable target of 120 systole and less than 120 systole in KDIGO guideline, I would take that with a pinch of salt because of multiple factors. One, the only evidence or only study or RCT that has made KDIGO to go for this suggestion is your sprint. Beyond that, there is no major this thing. But unfortunately, sprint, if you go through the sprint trial in detail, greater detail, most of the diseases whom we are coming across frequently, like proteinuria more than 1 gram per day, non-glomerulonephritis, about to be on immunosuppressive medication, ADPKD, and stage 4 and 5 CKD, all these patients have been excluded from sprint. So only a small subset of them have had CKD in the sprint trial. So that is the only evidence. Otherwise, no, there is no major evidence to go for such a stringent BP. That is number one. Number two, the sprint is BP recordings or standardized BP recordings, which you cannot practice in your office. For adopting that, it will take at least 10 to 15 minutes to check BP for one patient in your clinic. 5 minutes of just remaining the physician and the patient just remaining quiet for 5 minutes, and 3 readings, no coffee for 30 minutes before that, and all those things, it is impossible. So, and there is a nice comparison. One study has compared the BP reading measured using the standardized technique vis-a-vis the BP reading routinely that is being done in our office. The 120 of this standardized technique, the same person, if it is just done casually in the routine way, it is 135. So what does it mean? If you achieve about 130 or 132 in your office reading, that is equivalent to the 120 of standardized BP reading. On the other hand, if you try to push BP down to less than 120, by standardized method, you are putting your patients at risk of postural drop in BP, fall and fracture, worsening of renal function AKI, and so on and so forth. A lot of issues. And there is no robust evidence, number one. It cannot be generalized. Maybe in a very select patient, you can do that. And the proportionate benefit also has not been shown. The only trial that can be compared with this is ACCORD. ACCORD, it has included diabetic nephropathy patients with CKD and so on. Even in ACCORD, there is no robust evidence to show that very intensive blood pressure control is really clinically translated into benefit. So I wouldn't try that stringent BP control like 120 and so on. And to achieve that, polypharmacy is required, and the polypharmacy will worsen your non-adherence problem. So all these issues are there, and maybe in a selected patient in whom everything is fine, considering the safety and so on, I'll go ahead. That otherwise, I'll be comfortable with 130, systolic BP of 130, 135, and so on.
Point well taken, sir. And I think we certainly keep to individualize our treatment so that the patients do not get into trouble, and we are able to achieve as best would be the word, rather than trying to all the time focus on what the guidelines tell us. We certainly need to keep them in mind, but then, as I said, individualize according to the needs of the patient, because not everyone is alike, and one size doesn't fit everyone. So points well taken, sir. But then certainly the guidelines talk about these, so we have to certainly go by trying to achieve those kind of targets. And before I ask Dr. Pratik Das to let us know what kind of targets does he have both for the CKD population, but in particular about those patients who are on dialysis, I will ask Dr. Dogra to tell us which of the different techniques. You see, this when we are going to depend a lot on the very minute fluctuations, when we believe that every millimeter counts. So obviously, the way we record it, as has been highlighted by Dr. Deepak, the right way of taking the blood pressure, but then also coupled by the fact that we have the white coat hypertension, we have the masked hypertension at the same time, the totally opposite of that. So here it is extremely important to know what kind of technique is important. Is it the office blood pressure you would rely at all? Would you always go in for an ABPM, which we know that may be in kind of idealistic but very cumbersome? Or would you, as has been advocated, ask the patients to purchase a good BP instrument for their home readings, and we refer to them? Over to you, Dr. Manu Dogra.
Sir, good evening, sir. Thank you for making me part of this excellent discussion, sir. So, coming to the question, there are many techniques of BP measurement outside the office, sir. So, I'll divide it rather into a validated conventional methods and non-validated unconventional methods, sir. So, validated conventional methods are home BP monitoring. You purchase a machine, you do either intensive BP monitoring, do it 2 or 3 times in a day for 7 days altogether, so that you come to know about how your BP is behaving along with your drug intake. Second is relaxed home BP monitoring. That is, you take it once a day, or maybe after 3 or 4 days, you take one reading. The second is ABPM, sir, ambulatory BP monitor. Why this is important is because, like you said, there's a very high incidence of masked hypertension and white coat hypertension. Both are converse to each other. The incidence of masked hypertension is around 8 to 20% in various studies, and white coat hypertension is 30% of all the CKD patients. So the idea is to catch these early, because what are we aiming at? We are aiming at to check the BP variability, the effectiveness of BP target achieved, and to check the absence of nocturnal dipping, or it's a reverse dipper. And what about the unconventional and non-validated methods? Sir, we are in the era of artificial intelligence. So there are many bands or smart watches which give you BP records with applanation tonometry. So we should not be closing our eyes to it. This might be the future. So as far as ABPM or ambulatory BP monitor is concerned, I would like to have ambulatory BP monitoring of all my patients once in at least 6 months, so as to know whether the drug is effective, are they able to achieve the targets, and they are not overestimating the targets, or they are not, overshooting the targets so as to put them risk of reduction in EGFR and further kidney damage. That is my take, sir.
Very nice. I think very nicely summed up, Dr. Manu. And I think, as you rightly pointed out, AI or the technology in future is going to be a very, very important thing for all of us to realize the importance of and imbibe whatever it throws at us. So with open arms, I would say. So over to you, Dr. Pratik, now. We have been talking a lot about the targets. So what kind of targets do you have in mind for your patients with CKD? It's not just hypertension. The viewers should mind. It is basically, we are today talking about hypertension in the context of chronic kidney disease, and no one better than Dr. Pratik Das with his tremendous experience. What kind of targets does he have in mind while patients, both of the pre-dialysis and also the audience would want to know about your targets in the dialysis population? Yeah.
Regarding this blood pressure control, one thing is a target we have been given for these patients of CKD, and whoever in clinical practice we know is how much difficult to get into any sort of target that has been said by different authorities. So usually for the initial phases, there is a connotations that we should reduce the target to 130/85 in a proteinuria patients, maybe slightly higher in the non-proteinuria patients. Now the JNC guidelines told there is a blanket one, 140/90 should be the adequate one for the CKD patients, particularly who are not on dialysis. And now after this post-sprint trial, the target has been lowered down, especially by the non-nephrology trials. They have been targeting that it should be low. But presently, for the non-dialysis CKD patients, we can suggest a slightly stringent target to being, if there is a 120/80 is achievable, that is well and fine. But if the patient is proteinuric and not requiring much more drugs, but if the patient is requiring 3, 4, 5 drugs, you have to assess the drug side effects also at the same time. Just reaching the target, you can achieve, as Dr. Gopal Krishna was saying, multiple falls, then fractures. There are so many things in the elderly patients. So for a CKD patients who are not on dialysis, it is well and good to be in the tune of, in the clinical practice, to be in the 130 and the 80 range. If this is achievable in the office, I think this is well and good. And for the dialysis patients, this is slightly different, because if the patients are undergoing hemodialysis, achieving a dry weight is sometimes very important, and every day the blood pressure cannot be same. Some people are getting hypotension during dialysis, some are getting hypertension, severe hypertension during dialysis. For them, you have to individualize in the two things, individualize the patients who are tolerating the antihypertensive drugs well and having a maintained BP, then you can target a fixed one. Otherwise, in other patients who are fluctuating BP, either hypo or the hypertension, you can plan for the non-dialysis days to keep your target. And for the dialysis days, for developing a normal or hypotension during dialysis, you can skip an antihypertensive drug, and maybe you can try to keep this level slightly higher. And the patients who are achieving a higher level, then you can prescribe the drug and keep your target in the tune of 140/90. So for the dialysis patient, for the non-dialysis days, it is better to have in the tune of 130/80. And in the dialysis days, it may be 140/90. That gives you better dialysis, better fluid removal, and ultimately long-term benefit in terms of survival.
So excellent points. And I think, again, that brings us to the importance of individualizing your therapy, so that the patient in front of you doesn't suffer just because you were wanting to blindly follow the guidelines and disregarding the fact that a given patient is not able to tolerate that kind of blood pressure target. But certainly, what we agree upon is we are talking about a similar kind of range and not wanting to go totally off the targets. So Dr. Vinay, this one brings us to a very important aspect. We do realize that it's the variability in the blood pressure which really plays havoc with the patient's target organs. So would you want to have those kind of drugs which give you a peace of mind that yes, blood pressure variability? Because you see, I will be more fearful of a blood pressure range that it's 180 in the morning systolic, and it becomes 106 late in the evening when you have given so many of antihypertensives. So it's a wide fluctuation between and the pendulum swinging on either side. So would you want to prescribe those kind of drugs to your patients which do not allow such kind of variability to happen? And again, in the context of chronic kidney disease, what is your take on the importance of nocturnal dip? Would you really want your patients to have that kind of nocturnal dip in their blood pressure? And what would be your strategy to time the blood pressure medication?
Yeah. So very good question. So now the question is, why does this BP variability matter? So why we are worried about this BP variability? So whenever there is higher fluctuations in blood pressure, whether it is between visits or during the day or at night, it can cause more kidney damage than a consistently high blood pressure. So if one patient is having consistently high blood pressure and other is having this fluctuation in blood pressure, so fluctuation will cause more damage than a consistently high blood pressure. Second is the role of non-dipping BP at night, when BP does not drop by at least 10% or increases during the night, or we have the reverse dipping. This again increases the risk of CKD progression. Even the sprint trial showed that BP variability leads to faster decline in kidney function, even if the average BP is controlled. So how we can check this BP variability in practice? We can first use the 24 hours BP monitoring at least 6 monthly or once a year for our high risk patient. Then we can have home BP monitoring. Then you have to look for the pattern, whether this BP drops at night, which is the normal, or is BP changing a lot between the visits. So what we can do for these patients, we can use long acting medication. Then we can time the this antihypertensive medication. So nighttime dose can be added for these non-dipper type of patients. So we can add the nighttime dose. We can use the long-term medication, and this pattern of BP variability definitely is going to cause more harm, and it has to be checked.
Well, thank you. I think that's very useful information which you shared. Dr. Manu, now I think we will be talking about a little bit about the various drugs which we have heard today, the importance of RAS blockers, and I would start by saying that maybe we have been a little unfair with the usage of RAS blockers. I mean, I think when we go to any international meeting, it comes as a surprise to see that the whole world is actually reposing their faith on RAS blockers, and somehow the usage here in our country is not optimum, and it needs to be increased. So certainly it brings us to the point: where would you position RAS blockers when you talk about chronic kidney disease? Would you believe that hyperkalemia is bound to happen, so that'll stop you from going ahead with the usage of RAS blockers and continue to use drugs like calcium channel blockers, which of course there is no controversy around that, but then straight away going for these central agonists like clonidine or moxonidine, or even for that matter alpha blockers. So where would you position RAS blockers while you are managing your patient with hypertension?
Sir, I echo your statements absolutely verbatim, sir. It's a surprise for us when we go to meetings and see the faith in RAS blockers of the international fraternity. We use RAS blockers, we all know there's no contest about it. They are wonderful drugs, have been known to prolong the CKD progression, and has got many beneficial effects, including a reduction in cardiovascular mortality. Now, coming to the question of dual RAS blockade, sir. Now, RAS blocker, we should go to the optimal dosage, but when we are using dual RAS blockade, it is definitely beneficial. Though the trials like On Target and Altitude trial and Valiant trial, they have all said that yes, there was a high risk of acute kidney injury because of the stricter blood pressure control. But the catch is the pressure control is much better when you have two RAS blockers. I include MRAs also into RAS blockade, sir. And non-steroidal coming with Fidelio and Figaro, it is definitely beneficial, sir. Now the question of hyperkalemia, sir. Now the dosages which have been used in all these trials have been very, very high. We do not have to go to that high dosages so as to generate an effect. So my take is we should do there are many trials like the Charm added trial, Valhef trial, where they have added ACE ARBs together, and the beneficial effect on cardiovascular mortality is definitely there. The patients have had a better blood pressure control, and hyperkalemia was not there because very high dosages were not given. They were moderate dosages. And secondly, sir, as Dr. Deepak Panigrahi and you yourself told in that stop ACE trial, sir, we should not be stopping ACE inhibitors or ARBs. They are beneficial, sir. So my take would be, we have been using it in nephrotics, sir.
So very important point, sir. Very, very important point. And I think we need to differentiate the on-target. The caution with on-target was in the case of diabetics. And I think when we talk about CKD, we also have to be mindful of those non-diabetics who have proteinuria. And there, of course, the maximally tolerated dose, and you may consider adding. But then I think the stumbling block always, not always, but quite often, is the risk of hyperkalemia. And my question to Dr. Gopalakrishnan, would you at this stage want to stop? Now, typically the question asked to each and every nephrologist, always for the last times immemorial, when do you stop? Rather than continuing to repose your RAS blockade, the question is always asked, when do you have to stop? So one of the reasons is hyperkalemia. Would you, again, in your clinical practice, want to stop RAS blockers, ACE inhibitors, ARBs, or you want to give them the benefit of doubt while concomitantly giving them a potassium binder. So what would be your take? We know that the newer ones, the novel ones, zirconium cyclosilicate, petiromere are not yet available. But why not the time-tested polystyrene, the calcium or the sodium polystyrene, the K-acylate? Would you want to continue RAS blockers along with them?
Yeah. Before answering this question, a couple of points about ROS blockade. Whenever we prescribe, we have to ensure, particularly in a lady still in the reproductive age group, pregnancy should be ruled out. That's number one. And number two, mandatorily, when you initiate a person on ROS blockade, after a week or so, potassium and creatinine have to be rechecked. If the rise in creatinine is more than 30% from the baseline, you have to think twice whether to continue or not. So these are basic things. And more importantly, when you add a diuretic, you have to be extremely cautious to keep a watch on what's happening to the renal function. And then the 6-day holiday that is important for ARBs and ACE inhibitors. And preferably, it has to be temporarily withheld in the perioperative period. So these are sometimes, because not following these basic things, sometimes we land in trouble. That's number one. Number two, most of my patients, they don't tolerate dual RAS therapy and so on. So I never ventured. And also in the literature, also there is conflicting reports, and there's no robust evidence to suggest that that gives an added or synergistic effect. So that's number one. And the stumbling block here is hyperkalemia, and hyperkalemia. And again, the person who's on RAS blockade and doing very well, in the month of May in Tamil Nadu, for at least a subset of my patients, I withdraw because there is a mango season. And every person is so fond of mango, and in spite of all our kind of advice, they venture on that. And again, consumption of dates, particularly during the Ramadan month and so on. So we have to make a specific interview with the patient, consumption of these dates during a particular season and this thing. So that's about it. And coming to this question, I would love to continue and step up the dose and uptitrate the dose of ACE inhibitor or ARB in every patient whomsoever I come across, because the benefit has been proved beyond doubt, meaning in all possible endpoints, not just renal protection, cardiovascular events, and so on, everything. But the problem is hyperkalemia. And when hyperkalemia comes, I don't dare. I continue until the potassium crosses 5.5. I don't stop. As a knee-jerk reaction, I don't stop at all. Up to 5.5. Beyond that, I'm a bit scared, even if the patient is asymptomatic, even if there is no gross ECG evidence. I don't know whether what I do is right or wrong. I am not able to continue. To start with, I just off the dose and then see again. And if it continues like that, I'm forced to withdraw. And this, the therapy for hyperkalemia, whatever is available currently in India, it is not really safer for long-term use. It can be used only for few days, and particularly the GI effects and so on. And there are certain potential disturbing side effects are there for that, and long-term basis is not enough. Now, in the literature, having said that, in the literature now, the current trend in the Western world, particularly many societies, have come up with position statement. Don't stop RAS inhibitors, and you continue along with the newer anti-kalemic, hyperkalemic drugs, the petiromere and sodium zirconium cyclosilicate, and both these drugs have been proved to be effective and well tolerated, and with acceptable side effect profile and so on. But I think the cost is pretty high. One, it is not available, and even if it becomes available, I don't think it can reach the masses in the near future. I'm just envisioning a day to come when these drugs are available and we are able to widely practice and give it for a large population. Really, that will be useful in our practice, so that we can continue RAS inhibitors and even MRAs as well.
So that's very important, I think. Dr. Gopalakrishnan, the points which you have raised, I think reinforces our faith in the continuation of RAS blockers, and certainly we'll find ways by which we can mitigate the existence of hyperkalemia. So points well taken. Thank you very much. And I think we move on. Lots and lots of questions, and very great piece of information which I'm going to share. We have crossed all-time high today of the people who have logged in. It's already crossed 2,000 people. So that speaks volumes of the kind of interest the Nephro Live additions have generated over the last couple of years. This one is for you, Dr. Prateek. Dr. Prateek, you talked about individualizing therapy. And certainly in the current context, Prateek, if I may ask you, where would you position the drugs like SGLT2 inhibitors and GLP-1 receptor agonists? Because you see, a lot of these patients have coexisting diabetes and diabetes, kidney disease, and we know hypertension is an integral part so very often. So how would you place, because we are in an era where we are suddenly trying to imbibe whatever is coming our way via these very, very effective novel molecules. So where do you position SGLT2 inhibitors, Finrenon, GLP-1 receptor agonists, and then, of course, try to see what it can do to hypertension? Because we know, as Deepak has said, SGLT2 inhibitors lower BP. We know that initially we believed that the non-steroidal MRA, Finrenon, did not have any effect on hypertension, but that is not correct. Probably we have encountered that, yes, it does have an effect. So what is your policy, Prateek?
No, basically, this pillar-based therapy has come particularly for the patients who have non-diabetic. They have a slightly lower GFR in the tune of maybe 60 or low, and they have some amount of proteinuria. So to improve the cardiovascular as well as the renal mortality in such patients, these drugs should have been used. But in many situations, we get the prescriptions prescribing almost all the drugs as a blanket treatment so that it will prevent the mortality. So it should be, in my clinical practice, we sequentially, with time, with lots of evidences that the SGLT2 recommendations and guidelines that can be prescribed as a first-line agent for such patients who is having this is slightly proteinuria and lower GFR. Till now, the patients reached a very low. So in those situations, if we can use with AC inhibitors or the ARBs as a first line of agents, that will give some amount of reduction of proteinuria, preservation of GFR, and cardiovascular mortality. And the rest of the things, the other two pillars that has been practiced, one is this is MRAs as well as this GLP-1 analogs. These should be individualized because there is, with time, the evidence says there is no alternative of using this ACs and the ARBs patients who is even having a GFR, slight proteinuria, and a diabetes. And there is also, we should not deny until and unless it is not tolerated due to side effects, SGLT2 inhibitors. But other two drugs that should be used in individuals, not as a first line in our practice, and also recommendations. These all trials regarding on the Finrenon, they say that these patients should have some amount of the proteinuria because the evidence told that non-proteinuric patients have practically very little benefit, particularly if the patient's GFR is more than 60 and there is no proteinuria, there practically no benefit. So some amount of proteinuria should be there. Patients should receive the maximum tolerated dose of this SEs and the ARB, not maximum tolerated, but this should be the SEs, ARBs should be there in the prescription. So in addition to that, if the patient doesn't improve, and in those situations, we can prescribe these MRAs. These MRAs have this is again concern is the hyperkalemia, but is much lesser compared to the spironolactone and this one. But it should be started, monitored potassium after 4 weeks of time. If still there, you can increase the dose and you can continue it. It adds to the cardiovascular as well as the renal benefit. But many situations, including the KDIGO, also recommends not to use them in the situations of hyperaldosteronism. If the patient has a simultaneous heart failure with a low ejection fraction, we should not prescribe these MRAs. Rather than we should go ahead with this spironolactone group of truly mineralocorticoid antagonist. Non-steroidal one should not be used. The spironolactone should be a better choice. In any situation, we will have a very high this is RAS activity. So this Finrenon is added in such patients. that is a good option. If the price is low, and then it's okay. Experience with the GLP-1 is lesser, particularly as a nephrologist. I am not very conversant with the use of these drugs. That should be selected in a specific group of patients, particularly their anti-glycemic actions is slightly good compared to the SGLT2 inhibitors. Their anti-obesity actions are well known. So if a patient have a diabetic and well metabolic syndrome, overweight situations, with a requires some slightly more control of diabetes in some situation and can afford, that is one important thing, because this drug is very costly. And then we can use these GLP-1 analogs, and the recent flow trial has also shown us that yes, it has a benefit in terms of the CKD progression regression. So my take on in this, we start with the ACs and the ARBs as well as plus SGLT2 inhibitors. Wait for some, if this is not so, we can, because all of these drugs will reduce some amount of GFR, and if creatinine goes up, to the patient will come and tell you why my creatinine has gone up. So you will give better and give a gap, and after that you can start a finerenone and GLP-1 analog as it is required. So pillar-based therapy should be after another in a sequential one, not as a blanket treatment to everyone.
Well, I think thank you very much. I think that brings us to a lot of questions which are there in the chat box. We are flooded with questions today. In fact, Dr. Vinay, before we take up the questions, one last one for you. Do you think we have been very optimistically talking about the non-steroidal MRAs? Do you think they are going to replace the traditional thiazides? Are they there as yet? Because every day, the way we used to hear about SGLT2 inhibitors, we are hearing a lot of good things about the non-steroidal MRAs. Do you believe they are going to replace the traditional thiazides?
So as you yourself has mentioned that they are not very potent antihypertensive. They have got so many pleiotropic effects. So whether it was the Fidelio or Figario, the BP reduction was not that very high. In fact, in Fidelio, it was to the tune of 3 to 5 millimeter mercury systolic. In Figario, it was 2.6. But in clinical practice, definitely we see that they have got good effect. Definitely, they reduce the other pleiotropic, their effects are there. So if we compare them with the traditional diuretic, we have three type of diuretics: thiazide or thiazide-like diuretics. You have the loop diuretics. You have the potassium-sparing diuretics. For thiazide diuretics, whether it is the chlorthalidone or indapamide or the other thiazide-like diuretics, you can use till the stage 3, CKD stage 1 to 3, when the eGFR is more than 30 ml, you can use. But there, we have seen that in the click trial, chlorthalidone was shown to be superior to the thiazides. Chlorthalidone was better in CKD. Loop diuretic, when the eGFR is less than 30, you can use in stage 4, 5. But if you are using finerenone, the BP lowering effect is mild to moderate, but there is significant albuminuria reduction. There is significant CV protection. It is going to reduce your risk of heart failure, the MI risk. But spironolactone, when compared with finerenone, spironolactone is more potent antihypertensive, but we have to again look at the potassium levels. So
we are running out of time, and I think you've actually very pointedly answered what Dr. Bhavsar wanted to know, and his question was that why the choice of diuretics differ. And I think I want to remind everyone that when we are looking at thiazide-like diuretics, including chlorthalidone, it is basically predominantly the antihypertensive effect. So they should be viewed as antihypertensive drugs rather than merely diuretics, which are going to make the patient urinate more. So I think we need to look beyond this comparison, and that is why when it comes to the control of blood pressure, we are all the time talking about the thiazides and thiazide-like diuretics rather than loop diuretics, which certainly are very effective to decongest a given patient. And Dr. Gopalakrishnan, this one is for you. Dr. N.P. Singh, who is sitting in US at the moment, asked us a very pertinent question. How can we prevent the progression of CKD by using all preventive therapy and without increasing safety concerns? This is the most practical tip you can give to the audience today as to how to prevent. And Manu, I'm going to ask you after this, what is your take on the lifestyle? We can't move away from the lifestyle management in these patients as well. Over to you first, Dr. Gopalakrishnan.
Yeah, the CKD progression retarding the progression of CKD. Am I audible? Yeah.
Yes, sir. Perfectly well.
Yeah, fine. See, I think the first line of drug therapy, antihypertensive and antiproteinuric, is RAS inhibition. Unless there is a contraindication, unless there is a safety concern, unless there is an issue of non-tolerability, one should not stop that. And again, even before stopping, you have to kind of reduce the dose and see. And when there is hyperkalemia, also you can add a diuretic sometimes and very strictly advise dietary restriction and so on. You try all the measures and then finally you have to take the decision of withdrawing that, number one. And there should be more and more of sensitization and conviction about the role of RAS inhibitors in CKD progression. That is number one. And number two, SGLT inhibitors. Definitely a wonderful molecule. It's a wonderful molecule. Now the initial the hesitation and the fear, all that is gone. Only thing is that there should be a strict health education to the recipients of SGLT inhibitors to watch for the genital infection, urinary tract infection. Again, drug holiday during acute illness and during fasting should better to avoid and so on. And again, perioperative period, it has to be avoided. And what I do is that, before starting SGLT inhibitor, I make it a point to clinically examine the peripheral pulses. I have a very low threshold to ask for Doppler lower limb, Doppler study of the lower limb vessels before starting on SGLT inhibitors, because there are some studies where there is increased incidence of amputation. So these are the points. So that is renoprotective. And the GLP-1 receptor agonist, more and more of Indian data has to come up. The Western data is fantastic and fine, but again, we do come across many side effect profile also. For instance, ischemic anterior, the optic neuropathy, and the podocytopathies and so on. So, I mean, even though it seems to be wonderful, we have to generate more and more of Indian data of GLP-1 receptor agonists. Again, the cost factor. And then non-steroidal MRAs, definitely wonderful. But I'm a great prescriber of spironolactone. The beneficial impact of spironolactone, one has to see to believe it. But again, the problems are gynecomastia in males and then hyperkalemia. So these are the points.
Yeah, so we have to
and
be
lifestyles
careful.
are very important.
Yeah, I'm sorry to interrupt here. Just for the positive time, I wanted to include as many questions. Your points very well taken, most aptly described. This was a question by Dr. Verma. Does hypertension management differ in dialysis versus non-dialysis? Well, not really, Dr. Verma, but then I think you will find it increasingly difficult to continue with ACE inhibitors, as we have discussed, because of the risk of hyperkalemia. So you will have to find ways to mitigate the occurrence of hyperkalemia, but certainly. And then as the stage advances, the sympathetic overactivity also plays up. And by the time they are on dialysis, you may have to actually favor the inclusion of beta blockers as well. A lot of very controversial
and progressive reduction in the dry weight. Progressive reduction in the dry weight also can be attempted in dialysis patients.
Certainly. So basically, as you move, there's a paradigm shift as the way the blood pressure control becomes difficult, and very, very often you find practically every drug being offered to our patients who've been on dialysis for a very long period of time. And I think there was another important thing. This was by Dr. Krishna Verma. He's raised a very, very pertinent point, which we as nephrologists see very often. Very difficult to control blood pressure in CKD5D patients, those who are on dialysis and have to be started on rifampicin. It is a nightmare at times. We so many times have actually to stop rifampicin because rifampicin makes the task of calcium channel blockers very difficult. So anyone can volunteer. Dr. Manu, would you want to take? There was a beautiful article from All India Institute way back in 2012 or 13, where they first raised this observation that, well, it becomes increasingly difficult to control the blood pressure of those patients who are on rifampicin as a part of anti-tubercular treatment. Calcium channel blocker dose has to be jacked up very, very drastically, and we struggle at times. And I think so many times we encounter patients coming back with hypertensive emergencies, and we have out of compulsion to stop rifampicin these patients quite often. Manu, your take on this?
Sir, it is absolutely true, but we do not stop rifampicin upfront. We
Yes, of course.
keep on hiking up the dose because rifampicin is the basis of antitubercular treatment in India. So we
Yes.
have to be very, very careful. We have to try various therapies. And here comes the role of renal denervation, sir. Because this is a subset of patients who is going to benefit with renal denervation, sir. Otherwise, whenever rifampicin is started, the dosages of antihypertensives are hiked, sir. Sir.
So that's point well taken. I think this is again highlights the importance of renal denervation. I think Dr. Deepak very amply highlighted. I think this discussion is going to go on, and I'm quite excited to have such a lead panelist. This thing. So Deepak has done a fantastic job. Deepak, would you want to add any information to what we have done while addressing the queries of the people who have posted their questions? Dr. Reddy asked, do we take any special precaution in patients with a single kidney, hypertension with a single kidney? I think probably the answer is no. We have to take it as per the level of the blood pressure and take it further. Patients with single kidney may have a secondary FSGS, and that may actually compound the matters, make it more difficult for us to control their blood pressure. And so many times you actually will have to treat the way you typically treat a patient with resistant hypertension here as well. Glomerular disease is always a nightmare. So many times it is increasingly difficult to control the blood pressure in these patients. So with that, there have been very nice messages from so many of those who have joined. Thank you very much for those kind words. And the last word by Dr. Gopalakrishnan before I hand it over to the organizers of today's session.
So I just want to emphasize one particular point. Everybody knows it's not a new point. Thiazide diuretic and thiazide-like drugs are wonderful drugs in reducing the blood pressure because a significant natriuresis happens compared to loop diuretic. With thiazide diuretic, the quantum of natriuresis that's happening is really, really good. So the volume reduction happens. It is fantastic drug. But one has to remember, it is a double-edged sword, like, the propensity for causing severe hyponatremia. If you don't have a mechanism of periodically monitoring sodium, better don't prescribe at all. Because, the hyponatremia, severe hyponatremia is a killer. And many patients who are asymptomatic chronic hyponatremia also adds on to morbidity. Initially, in the past, it was thought to be benign, but it is not so. It can contribute for dementia. It can contribute for frequent falls, can contribute for osteoporosis and fracture. So it's a wonderful drug, no doubt. Now, trial has suggested hyaluron even in stage 4 CKD.
Yes,
that's fine.
So, no, excellent point, sir. And I think this certainly needed to be highlighted. The way we look at potassium, and I think it's equally important to be careful, mindful of sodium as well. I think as you can see, this discussion can go on, and I'm here to learn as well. But then certainly time comes in the way. Our special thanks to those people who have joined from other countries as well. We have this congratulatory message, a thank you message from Dr. Parminder Chawla from USA, who has really liked the discussions today. Thank you very much for many other such congratulatory messages. Thank you very much, and over to you, Dr. Mithilesh and Gaurav, for winding up today's session. I'm sorry we have overshot one more time, but then you see when the discussion is. Deepak, do you want to make a last minute comment before we hand it over back to the organizers? You are on mute, Deepak. Kindly unmute yourself. Yeah.
Sir, you should not be. I am really sorry, sir, for the extra plus of the time. I took more than what was allotted actually.
That's absolutely fine. So very useful, I'm sure. Over to you, Gaurav.
Yeah, thank you very much, sir. So it is my privilege to deliver the vote of thanks. First and foremost, I extend my heartfelt gratitude to our esteemed speaker, Dr. Deepak, Dr. Gopal Krishnan, Dr. Vijay Malhotra, and Dr. Pratik Das, and Dr. Manu Dogra, sir, for sharing their expertise and their valuable clinical insight. Your wisdom help us in gaining valuable clinical takeaways. You have guided us with practical and actionable takeaways regarding the management of hypertension and kidney disease. A sincere thanks to our esteemed course director, Dr. Dinesh Kullar, whose exceptional leadership has been the driving force behind this engaging discussion. And we are doing this since last four episodes. And now, as sir is doing excellent discussion, we are gaining the attention of audience significantly, and we are witnessing almost 2,000 participants today in our program. So we also extend our gratitude to all our incredible audience who have joined today and for their active participation. Lastly, a heartfelt appreciation to our dedicated tech support team for their seamless support behind the scene. Thank you all for your valuable support. We eagerly look forward to welcoming you all in our future sessions. With this, thank you and good night, everyone.
Thank you, sir.